Professor Ruth Nduati. Professor Nduati is an internationally recognized authority in mother-to-child HIV transmission. She chairs the Department of Pediatrics at the University of Nairobi. She's led a number of important clinical trials looking at interventions to reduce mother-to-child transmission of HIV, including the Kenya breastfeeding versus formula feeding study, and more recently the Kesho-Bora study. She has recently also been leading a PEPFAR program implementation award, which provides prevention of mother-to-child transmission services to 17 districts, 450 different facilities throughout Kenya, which provide about 10% of all of the Kenya data, the national data on PMTCT. Professor Nduati.
Thank you.
Welcome.
Thank you very much. Thank you, Scott, for a very generous introduction. I will talk a little bit about a little bit of background on PMTCT, just so that we are all the same wavelength. I then talk a little bit about our Kenya program, what we are hoping, what have been our achievements, what we are hoping to do, and what really needs to be done. And I'm going to emphasize areas around implementation science, the need for research to actually accelerate the scale-up of PMTCT and learning around health service delivery. Now, we all know that without any interventions, if an HIV-infected mother would transmit to her baby, and out of 10 women, 3 to 4 of them would transmit. About 10% of that transmission would take place during pregnancy, about 10 to 20% during the time of delivery, and another approximately 15% postnatally through breastfeeding. And the magnitude of the postnatal transmission depends very much on the duration of breastfeeding. So shorter breastfeeding, less transmission, longer breastfeeding, more transmission. And but having said that, the period of the first 6 weeks is a time when babies are quite vulnerable. In our early work, where we randomize babies to breastfeed and formula feed, 60% of the postnatal transmission had already taken place by 6 weeks of life. Now, a lot of progress has been made in the last 10 years in terms of preventing mother-child transmission of HIV, or let's say 15 years. The 076 was presented in 1996, I believe, yeah? And since then, tremendous progress has been made. Here in the United States, you talk of eradicating mother-child transmission of HIV, and we in the developing countries, we're just now seeing the opportunity to do that. The 076 protocol gave mothers antiretroviral drug therapy during pregnancy, during the time of delivery, and postnatally to the infant. Now, at that time, the drugs were really expensive, so research projects were set up to look at, if you only give it around delivery, if you give it to mom and antenatally. And finally, the last round of studies have been, if you prophylax the infant as they are breastfeeding, can you prevent infection? And the most recent studies show that you can actually protect breastfeeding for the HIV-exposed infant, and you get transmission rates less than 1%. And we are happy to say that we in those trials where you treat mothers who need treatment, or prophylax those who don't need treatment, or if you give triple ARVs to all mothers who are pregnant and breastfeeding, babies who are breastfed have better survival than those who are not breastfed. So we're really happy about that, because in our part of the world, not breastfeeding is associated with increased risk of death. It's associated with increased risk of malnutrition from very early in life. And malnutrition is probably the single most important contributor to loss of human capital around the world, and particularly in developed country settings. For those of you who may not read a lot around nutrition, stunting in young infants, and particularly stunting that is not corrected by the age of 3 years, results in long-term cognitive disability. That child, by the time they're in standard 6, they perform at around 2 years behind their age mates. And by the time they get to the workplace, they're and 20% less income. There are interesting studies that have been done a lot of it in Jamaica, and with long-term follow-up of children. So the interaction of HIV, breast milk transmission, and the need to ensure that children are well nourished and well protected from infection has really been a major public health challenge in our region. Now, the new WHO guidelines, what we call the 2010 guidelines, are good. They say that every HIV-infected woman should get a CD4 count done to determine whether they need treatment now or whether they can defer treatment. And then for the women who don't need treatment, there's an option, what we call option A, where we give them AZT and nevirapine prophylaxis or AZT prophylaxis for the infant. And for the mothers or alternatively, you put mothers on triple ARVs and you keep giving them the drugs until 1 week after they wean. We've also shifted from the old guideline of early weaning, where the guideline, the old WHO infant feeding guideline was to encourage mothers to stop breastfeeding after the first 6 months when, given that the first 6 months babies need milk only. We've moved away from that and encourage that mothers continue to breastfeed with ARV prophylaxis until a year and to try and wean the child after 1 year. So and then now more recently is what they are calling B+, and this is now related to looking at issues of mothers. Once you start them on ARVs, maybe you should just continue forever after. And there's a lot of debate, and some of the thoughts that are driving this debate is that it has been observed that HIV-infected women still go on to get other pregnancies, and there are concerns about repeated exposure to ARVs. What does it mean to them in terms of their own future treatment? There are few studies, in fact, one reported in a recent conference showing that in that next pregnancy, a significant number of mothers were already having low CD4 counts, so that they were in the realm of being at a very high risk of transmitting to their infants by the time they came in for their antenatal care. Now, we've been doing PMTCT for the last 10 years. A Kenya program was launched in 2002, and that's about the same time in the developed countries that really there was a major push to try and put programs in place. Now, in 2010, there was an analysis by somebody called Dr. Mahi, who brought in the data from 22 different countries and asked themselves, if we continue business as we are we going to prevent or protect babies from HIV infection? And their conclusion was that if we continue business as we are, we're not going anywhere. We're going to continue having thousands and thousands of babies who are HIV infected. And their hypothesis was that if we implement these new 2010 guidelines, but also address all the other strategies of primary prevention, meeting the contraceptive needs of women who are HIV infected, and provide ongoing treatment for children who get infected and their mothers, we may be able to achieve the goal of having globally less than 30,000 new pediatric infections per year. Now, Kenya, as a member of the World Health Organization, has adopted this and tried to adopted it and tried to develop a framework of implementation within the Kenyan context. And our stated goals for eradication of mother-to-child transmission of HIV is that we should eliminate transmission by 2015 through universal access to comprehensive PMTCT services. And we're saying that we want to make sure that every pregnant woman will have access to PMTCT services in Kenya. Now, this stated goal contributes to Kenya's health policy of eliminating communicable conditions, and also the National AIDS Strategic Plan, where we have a vision of an HIV-free Kenya. We are great dreamers, and we are working hard towards that, meeting those dreams. The overall target is to reduce mother-child transmission to less than 5% by 2015. That is not too many years to go. This goal recognizes that we may not be able to eliminate completely, but we think that we can achieve the goal of less than 5% infections. As a country, we have not gone the next step where we have tried to put a goal to how many children we would like to, how many kids would accept that as a reasonable number to be HIV infected, like the global goal where it says they want it to be less than 30,000. As a country, we have not taken that step. But the specific targets are, one, to reduce HIV incidence in women of reproductive age by 50%. And then the second goal is to reduce unmet family planning needs to 0. Currently, 60% of HIV-infected women have unmet family planning needs. And our national program says they want to reduce that to 0. Now, the third specific target is to reduce number of new child HIV infections by 90%, and also to reduce HIV attributable deaths among children by 50%. And finally, to reduce HIV-related maternal deaths up to 12 months post-delivery by 80%. Now, those are big targets. They are focused very much on, it's sort of like a disease eradication mode. We have had disease eradication activities in the past. There's the smallpox eradication program. There's a currently ongoing polio eradication program. I think in the past there was a malaria eradication program that was successful in your part of the world, and it's still a niggling problem in the tropics. And this week's Lancet actually has a very interesting commentary around disease eradication. If you give me a minute, just allow me to read a statement. It's a quote from a book called Eradication, Reading the World of Diseases Forever by somebody called Nancy Leigh Stephan. She says, this was on May 1980, the World Health Assembly endorsed the historic resolution that the world was free of smallpox. Soon after the assembly, I was angrily confronted by a senior WHO official who spoke slowly and deliberately. Let me assure you that that in this organization, there will never again be a vertical program such as smallpox eradication. Of course, we now have the hindsight of history to know that there has been other vertical programs, but even as we try to eradicate mother-child transmission of HIV, there are others who may be feeling that this is not the right priority. The folks who do metabolic disease are saying we have an outbreak of diabetes in Kenya. We should be putting money into that. This afternoon, there was a presentation by one of your colleagues who visited Kenya up in the north. There's famine out in the north, so we should be focusing that. So even as a national program tries to focus on this really noble goal of eradication, it is doing that in an environment that there are challenges and people who don't see that this is important. And this conflict is not just at the program level nationally, but you find it even at the level of the health service delivery. The lack of prioritization of this as a program. And these are some of the bottlenecks that have to be overcome if we are to achieve our goals. Now, the guiding principles, of course, for this effort are human rights and gender equity. Equity in terms of reaching everybody, so we have to develop a program or build a program so that you can reach Kenyans everywhere where they are. Integration and working with other sectors of the economy. For example, the areas of primary prevention, we really need to work with the education sector. You need to work with the development sector because that's where the people are. You know, we only see people for a short time when they're ill, or coming in for antenatal services or immunization, but the rest of the time they're out there in the community. it needs to be evidence-informed. Kenya receives a lot of PEPFAR money. In fact, this year, we've been declared unable to use all the money that we have received, and they are actually cutting back. But even as they cut back, it is a lot of resources. It needs to be spent on evidence-based interventions. And the evidence-based should not stop at the point of, we know that these ARVs work in a clinical trial. But even in the setting of delivery of health services, which is the most efficacious way of delivering PMTCT services so that you reach everybody and you're actually able to achieve that goal. And here then the need of what we call implementation science. There's a need also for being results-based as opposed to being process-based. Development work can actually become a job, you know, and a job doing development work for problems that never go away. And which is, you know, sort of counterintuitive, isn't it? And I think changing the paradigm where we now talk of results-based planning and management will then stop us from being just in the business of doing development this year, next year, apply for USAID grant, plod along for 5 years, apply for another development grant, maybe Global Fund or wherever, but keep doing the same thing but never really changing the situation on the ground. In fact, it would be interesting to go to the ground and do studies and find out what's been the impact of some of the development funds that have been around for a long time. So coming back to our Kenyan position, the question is, are we in a position to achieve these ambitious goals? Now, in 1999, we had our first pilot PMTCT programs in 3 hospitals and then scaled up to another 2. And the initial pilot sites were selected to represent the spectrum of where Kenya is. One was in a hospital in Homa Bay, which is in an area with the highest infant mortality in Kenya. At the time when we were doing that work, the infant mortality rate was about 200 per 1,000 live births. And then also in a rural district where we had low infant mortality at less than 30 per 1,000 live births. In the city of Nairobi. And then we then had 2 other provincial hospital and district hospital in a more medium kind of region of infant mortality. And our reason for doing this was that if you want to do an intervention, you must be able to implement it everywhere, where the resources are and people do well, as well as where it's much harder to implement. The goals then were to reduce infected children by 20% by 2005 and by 50% by 2010. What have we achieved as a country? We have some good achievements. We have more than 18,000 health workers trained on prevention of mother-child transmission of HIV. We have scaled up services to over 4,000 health facilities. We estimate that we have about 6,800 facilities. The facilities that we haven't reached are largely individual practitioner practices where they're seeing very small numbers of patients. But we have a goal that even in that environment, we should scale up PMTCT. Over 80% of pregnant women in Kenya receive HIV testing, and 81% receive antiretroviral drugs for PMTCT. Granted, about 1/3 of them are still receiving single-dose nevirapine. Dr. James Carey, who is, of course, some of you may know, led a team to do a PMTCT impact-based study. It was a cross-sectional study. And they found that the infant infection rates were about 7.7%. Based on that, a program where we're doing the AZT single-dose nevirapine. The triple ARV is only being used in the large hospitals, at Kenyatta National Hospital, in Pumwani Maternity, which is a huge maternity hospital with 25,000 deliveries per year, I think, in the city of Nairobi, and in one other university teaching hospital. But given this, we cannot celebrate. We've done well. I think we have done well, but we cannot celebrate. And let me tell you the reason why we cannot celebrate. Now, if we look at prevention of mother-child transmission, we have the 4 prongs where we talk about primary prevention. If we look at primary prevention, some of the challenges that we still face is that we have early sexual debut among young people. They have inadequate knowledge about HIV. There's low condom usage. And even where to access the commodities, young people don't know. There's high incidence of HIV among young women, and stigma and discrimination still abound. We have about 20% of young men having their sexual debut before age 20, before the age of 15 years. And this rapidly climbs to about 60% before the age of 18 years. And for the young women, about 10% are sexually active by the age of 15 years, and about just short of 50% by age 18 years. So we do have young people who, about 30% who defer sexual activity to beyond 18 years of life. It would be interesting to know why. What is it that is in their life? Why are we interested in young people deferring sexual activity? We find that among these youngsters, this year of 15 to 17 years, they have the highest rates of risky sexual encounters. In the Kenya Demographic Health Survey, 100% of the boys who are sexually active in that age group of 15 to 17 years are engaging in high-risk sex. They have partners who are not, non-permanent partners, and they are not using condoms. For the girls, it's about 3/4 of them, about 75% of them. For the girls, the risky sexual encounters drop quite rapidly to about 40% for the 18 to 19-year-olds, and you're down to about 20% in the age group 23 to 24 years. When you ask them about whether they use condoms, and particularly condoms on their first sexual encounter, very few of them do that, both boys and girls. And when you look at the slightly younger person, the 15 to 19-year-old, they're even smaller. I don't know whether if I looked at, if I did this, I don't know whether you would see this. Do you see the black blobs here? This middle slide, the very black blobs on that, is an indication of the proportion of young people who are having one sexual partner and are using a condom. So, so in terms of our success in that first prong of PMTCT, I don't think we're doing very well. We still do need to do more work. I think for me what is even more challenging is that in a country where we have very high HIV prevalence, 47% of young women, and only 47% of young women have comprehensive knowledge of HIV. And when you ask, do they know where to find a condom? The young men who are a bit more creative, among the age group 15 to 19, just over 80% of them know where to find a condom to protect themselves. And for the girls, 40% of them don't know. So I think we have work. We still have work to do to be able, if we are to be able to achieve our goal of prevention. If we look at women who have recently had a baby, Dr. Kinuthia, who was also a graduate of this school, did a study, his dissertation. He did a study and looked at women at 9 months post-delivery and offered them HIV testing, and then asked them about the HIV, whether they had tested during pregnancy and whether they were infected. And he found an incidence of 6.8 per 100 woman years of follow-up. I think Scott tells me this incidence is higher than among the sex workers he works with. And these are young women in a high HIV prevalence region. The risk factors for infection are also challenging for us in terms of prevention activities. One, young women who are employed. 2, being married. 3, being from a high HIV prevalence region. And 4, being in a polygamous marriage. Now, polygamy is alive and well in Kenya. And, but I think the challenge is, why would young women who are educated, who are employed, so have increased access to information, and so some level of empowerment, be the ones who have the highest risk of HIV infection? I think it speaks to an area of research that we have not addressed ourselves to. So if we look at this, this particular prong, 1, the primary prevention, for us to be able to achieve the goals that we set out of primary prevention, I think there's a need for improved determination of the incidence of HIV in this category of women and men, of course, so that we know whether we are achieving our goals. Right now we say, okay, we'll reduce incidence by 50%, but where is it and where are we going? I think there might be an opportunity to embed incidence studies within the Kenya Demographic Health Service or the Kenya AIDS Indicator Survey. These are big surveys done by the country, and in the past they've been able to ask people and do HIV testing as they do the survey, so we know what the national HIV prevalence is. But I believe we now have the technology within that context to be able to get an indication of the incidence of disease. I can see Kerry nodding her head. This might be something we could write up, isn't it? I think another approach is to do cohort studies in both high and low HIV prevalence regions to also to have a feel of what the incidence is. You know, sometimes in the low HIV prevalence regions, we may be sitting comfortably and thinking, we don't have a problem. But maybe that's where people are comfortable, and so prevention is not taking place, and new infections are taking place, okay? Now, how do we intervene in polygamous relationships? I have not yet seen any work around specifically working in this context to address the issues of infection. Now, what about these pregnant and lactating women who test negative, and then they are infected during the process of being pregnant and during lactation? Now, we can do couple counseling. And there's work that has been done around couple counseling. But the studies, when they were designed, they specifically excluded pregnant women. And any information we have is just that the women got pregnant in the course of participating in those couple studies. We have one study where we looked at uptake of couple counseling, but I think there's need for more work in that context. Now, how do you promote condoms for their partners? You know, do you have any studies that really just work with the pregnant women and show a methodology or a strategy, an effective strategy for promoting condom use by their partners? Male circumcision is very effective strategy of preventing HIV infection. I think the efficacy is around 67%. Do we promote male circumcision to partners of pregnant women? Would this be a strategy? Again, that could be a study, you know. What about PrEP and PEP for the HIV discordant couples? Do we need studies, again, in pregnant women to look at prevention? We know that from other I've not dealt with the non-Kenyan studies, but from other non-Kenyan studies, pregnant women have a 4-fold increased risk of seroconverting, you know, when you compare them to non-pregnant women. Now, what about the adolescents? These 15 to 17-year-olds, we always leave them out of our studies. It's hard to get ethical approval. How do we start working with the institutional review boards to enable a climate where we can actually do studies in these youngsters? Age 15 to 17 years is mid-adolescence. This is when the kids think, I'm invincible. Those problems are other people's problems. It can't happen to me. Now, how do you work with the young people with that mindset for prevention? Is it individual counseling? Is it modifying the institutions around them? If we made boarding school compulsory for that whole age group, would they make a difference? You know, And then the adolescents, the adolescents were not getting infected, you know. So we need to start doing what we call positive deviant studies to look at those who are not infected and find out what is it that has made a difference. These are our needs as living with the epidemic. Now, for family planning, as we said, we want to reduce the unmet needs to 0%. And our facilities are providing family planning services. In fact, over 90% of health facilities that were surveyed as part of this impact study have family planning commodities available. So really, we have the classic, we know what to do, but we are not doing, you know, the no-do gap. So there's need for operational research on how to meet these goals. Some of the question is, why are the health workers failing to offer the service? And why are the women and their partners failing to access the services? What are the myths around family planning and use of antiretroviral drugs? Because I believe that is one of the problems. And then, what are the myths around HIV infection status and continued engagement in sexual activity? There are many health workers to this day who believe that an HIV-infected individual has no right, has no business engaging in a sexual relationship with their partner. So if that is their mindset, they will not offer contraception. They will not engage in that communication. I know here we are the convicted and we will do the right thing, but we have to acknowledge that kind of dialogue is still there, even now, many years into this AIDS epidemic. The next big step is to reduce the number of new child HIV infections by 90%. Now, the Kenya Impact Study found that our transmission rate was the infection rate among the babies was 7.7%. So if we are to reduce it by 90%, we actually need to go to less than 1%. And the question I asked myself, what does this 7% mean? This was a cross-sectional study. And I can only conclude that this current rate, this estimate, is really the total number of infections minus the deaths of infected children. Remember, HIV-infected children have a very high mortality. 50% of them do not see their second birthday. And if you look at the children who die in the first year, many of them die within the first 6 months of life. So we have a challenge there in terms of, first of all, determining what is our base from which we are going to reduce the 90%. We do not have good data. Now, the Kenya Impact Study reached 1,000 HIV-infected women. They were HIV positive at the time they were doing the survey. And 71% of them reported that they were positive in the antenatal period and still got the interventions. But there's another 21% who said they were negative antenatally, and 5% who never tested. So again, opening up the window of opportunities around prevention. Do we give repeated testing every time mothers come? How often? Every 3 months? Every 6 months? In fact, if we didn't reoffer testing, I was estimating that you would have had the infection rate would have been about 11.3% in this group, because the mothers who got PMTCT, maybe they would have had the transmission rate of 5%, but everybody else who was negative at the time they were tested or didn't test would have had at least 30% or maybe even a higher rate of transmission, because you know when you're newly infected, you will transmit. So therein is a window around identification of women. Now, we do a good job of those who come in, we test and we identify them, but almost about 20% of women test positive and then walk away without getting their antiretroviral drugs. So why would somebody do that? We don't know. We don't really know, because when we do these surveys, we just count up the numbers. So again, there's research. There's a need for research around that to understand why because as long as they walk away, we cannot achieve our goal of eliminating mother-child transmission of HIV. About 60% of the children get the drugs. So again, there's another drop. And then finally, only a third of children who are HIV exposed are accessing PCR testing. So we are not identifying the kids who have failed who prevention has failed, and therefore we are not getting children on treatment on time, and hence many babies are probably still dying before they get onto treatment. Dr. Amalwa, who was doing studies around treatment of infants, found it very difficult to recruit because by the time we got to a point of recruiting, the babies were dead. We were not always sure whether the children died because they had an infection or whether there was infanticide, either by neglect. You know, baby is sick, my baby has HIV infection, I'm not going to take them to hospital, so they die from the pneumonia or from the diarrhea, or even other things. So again, studying the mental health status of young mothers of young infants who are HIV infected, and how we can best support them so that they can respond to their children. Remember, postpartum blues is real even when there's no HIV. What is the interaction of postpartum blues and a baby who is HIV infected? The feeling of guilt that I have passed on an incurable illness to my child. Again, we have not done studies around that. And I think there's now an interest in the mental health for HIV the neurological disease and mental health issues around HIV-infected individuals. And I think this would be an opportunity. We've looked at our data in terms of uptake of these ARVs across the region, and we find that where HIV is very prevalent, so it is real, they do very well in terms of delivering the antiretroviral drugs to the mothers and the babies. But where HIV prevalence is low, more mothers go away without their antiretroviral drugs. And I think that speaks towards stigma. And again, that is where HIV prevalence is very low, there's very high uptake of testing. But once you find out that you're infected, more mothers walk away from the interventions. So again, trying to understand what is going on there will help us improve our program. Some of the questions is, how do we position the things like CD4 count testing and WHO staging? These good interventions that improve the health of the mother may actually be a barrier to the delivery of PMTCT. If we require you to do a CD4 and the CD4 count is at the district hospital, but you have access to healthcare at a health center, you may not have the resources to go there, and you're not willing to say that I don't have the resources. So you go away and never have it, and you never get your drugs for prevention. So how to package it, you know, the wrapping on the sweet is important. Now, we want to reduce infant deaths by 50%. In the context of PMTCT, what is the mortality rate of HIV-exposed infants? Is it still that 50% that was based on children who had not been exposed to antiretroviral drugs? We have another category of children who we call HIV-exposed and infected. And these kids also have increased mortality and morbidity. What are the risk factors for death in these children? There are very, very few studies, and some of them very old, that suggested mothers' disease status, mothers who are more advanced disease, their uninfected children have higher mortality than if the mother doesn't have advanced disease. And we think some of it may be related to the transfer of passive antibodies to the baby from the mother. Or maybe the sicker mother has more illnesses that she's exposing her child to, or she's not able to care for her child. But this is an area that is begging for research. The effort to have an uninfected child is enormous, both in terms of the health worker activity, the parent, and also the financial resources. But we can lose it all if these children then die. Because really, once a child dies, that's a failed PMTCT program. So this, to me, is a new horizon in terms of research. So that we also know what interventions are we going to put into place. Maybe it's changing it requires changing the immunization schedules. Maybe, I don't know. We need to do the research. And for sub-Saharan Africa, these are very, very many children. Some of the data at the conference and also some of the epidemiological data, if you go into the Republic of South Africa, 1 in every 3 pregnant women are HIV infected. In Swaziland, 1 in every 2 women are pregnant women are HIV infected. You come to Kenya, there are parts of Kenya where 1 in every 4 women are HIV infected in the very high prevalence regions. In the city of Nairobi, 1 in every 10 pregnant women are HIV infected. So those are very, very many children who are HIV exposed and who I think we don't know enough about them. Now, when we look at the linkage between PMTCT and ongoing care, because that now goes on to the Prong 4, this pregnant mother who's HIV infected, is she getting her care? If you look at the data, we've been very successful. We have more than 600,000 people on antiretroviral drugs in Kenya, really, and in a very short time. Unfortunately, only 18% are women who have linked in from PMTCT. And yet the PMTCT program is the one that does a lot of testing, more testing than everybody. When we talk of 90% women accessing HIV testing, the national program estimates there are about 1.5 million pregnancies per year. So it's a lot of testing that is going on. And to have that only 18% of people accessing treatment are pregnant from PMTCT programs means that there's a failure there around linkage. And so the question is, how do we improve that? What are the challenges? Where are the gaps? Now, having said, sort of highlighted the issues around PMTCT, our national program has moved forward to pick up the 4 pillars of the eradication of mother-child transmission of HIV. The first one is advocacy and effective partnerships. We are clear that to move that next step, communities need to be vested. It shouldn't be that we pulling them. They also need to be delivering themselves to a facility and demanding the services. It's also partnership with local community NGOs, international NGOs. It is possible when you have such an appealing goal, everybody to be scrambling to get there, and you end up with chaos as opposed to moving in a program that is well organized and synergistic. So a big part is that advocacy. The second is the health system strengthening. We don't want to end up with a statement like the one from that WHO officer who was very angry that there was polio eradication, but malaria was still going on, alive and well, and all the other problems that were there. And also for us, there's also, it is self-serving also to strengthen the health systems because HIV is a chronic disease. And once you have gone through the initial PMTCT, we want to keep the mother alive. Our work earlier on showed that if a mother dies, the child has an 8-fold increased risk of dying, so that even if you're, regardless of whether they're infected or not. So as part of that success, we need to keep mothers alive. We need to get them into the programs, into care. And that can only happen if we strengthen our health systems. There's the need, Kenya has 6 layers of healthcare delivery, and the layer number 1 is community. And again, we have identified that community strengthening as important. We're training community health workers. Again, we need to ask ourselves, is this really the right approach? If you have a community health worker delivering services or doing the health education, do you have increased uptake or reduced uptake? Are the messages correct? Are people more likely to adhere to the drugs? Or should we invest in more professionally trained health workers to do that level of community work? And then, of course, finally, is the tracking the progress. There's no point of running a program without measurement. And how do we measure? We are at the transition between take-home records. I go home with my medical records and leave nothing in the facility. And at the facility, there's a register that's just a daily activity record. And transitioning into electronic medical records, which you need if you want to do chronic disease management. How do we do that efficiently and effectively? And how do you get the systems to work all the time? There are many things I think in this environment will take for granted, like your email works all the time, right? The phone works all the time, right? Electricity is on all the time, yeah. And which are not the reality in the part of the world where most people living with HIV are. And so we have to work within that context. And I believe even within that context, we can eradicate mother-child transmission of HIV, and we can assure people of a normal length of life, just like everybody else. We have mothers from our original study. That was 1991. So this is more than 20 years old. Their children are leaving high school. The children who are part of our breastfeeding study, for the moms who are fortunate enough to still be alive, their kids are finishing high school and going on to college. But too few. And we hope that with this expanded program, then all of them will be part of our future. So thank you. Let me stop here and just say I'm really sorry we couldn't share the slides, but I think I've covered pretty much what I had prepared. Yeah.